All right, we will go ahead and start right now. Hello, everyone. Welcome to our 2020 JPYC Shadowing Program. And really quick, we'll give you all a quick introduction of ourselves. My name is Rubaid Hussein. I'm a junior at Haynes Academy, and I am president of the JPYC.
Hello, everyone. My name is Jenny Chen, and I'm the vice president of JPYC. I'm a senior at Haynes Academy.
Hello everyone, my name is Philip Din. I'm a junior at Patrick F. Taylor, and I'm the treasurer for JPYC.
All right, and the other two officers who could not make it today are Eric Claris from EJ and Perry Basak from Country Day. Mr. Paul, Mr. Adam, do you two want to give a quick introduction of yourselves?
Sure. Adam, do you want to go first?
Sure. I'm Adam Campo. I'm with the City of Kenner with the Mayor's Office.
And my name is Paul Christian, and I'm the president of the board of directors of Louisiana Parlamento Conservatory, a music trade school in Kenner.
All right, thank you both. Now, as a community service club trying to get work done during a time as hard as this, we as the Jefferson Parish Youth Council have been trying to host events and take part in things that would help everyone try to return to normal. Now, we know a lot of people are worried about what path to take in the future. So with thousands of options, how would you choose a career that's right for you? Whether you have an interest or don't have any idea what you want to do, the task may seem insurmountable. Fortunately, the speakers we have with us today will be able to help you choose what journey to embark on by sharing what it's like to be in their fields. And with that, we would like to introduce all of you to Mr. Victor Simon and Dr. Serena Tang, our guest speakers for tonight. Mr. Simon, Dr. Tang, do you want to give a quick introduction of yourselves? Or do you want to get straight into our program? Your choice.
I will introduce myself during the course of the presentation, but I'm a petroleum engineer professional for 38 years. And so I'll give you a little bit more with the presentation. I'm glad to be here with you tonight.
I'm Dr. Serena Tang. I'm a pediatric and adult anesthesiologist at Ochsner Medical Center, and I've been practicing for the last 6 years there.
All right, thank you so much for offering to take part in our program. Mr. Simon, are you ready to start?
I will try.
All right, take it away.
Okay, hopefully everyone can see the slides that I've put up, and hopefully we can go through these quickly, and I will entertain questions after I'm done. I want to thank JPYC and all of its leadership team, and particularly Philip Din for engaging me and asking me to be a part of this, and Elias Alexander, one of your members, recommended me for this presentation. So I want to give him a shout out as well. I'm glad to do this. And as I've mentioned, I have 38 years as a petroleum engineer. I majored in mechanical engineering and minored in petroleum engineering. And so I've worked for 38 years in this industry. And so let me move on, and hopefully I can give some insight and stir some interest in engineering for those that are tuning in. For your benefit, my interest in engineering came as a child. I'm 67 years old, and so you probably won't be able to relate to much of what I'm about to share. Quickly, I became interested in engineering from watching television as a child, and I was watching a program that you have no idea. It was a game show called Truth or Consequences, and I noticed a lot of the candidates that are on the show said they were engineers. And the first thing I thought that all of these guys drive trains, and that was the only engineering I knew. And so I went to our encyclopedias in the house to find out more about engineers. And when I found out more about what engineers actually do, more than driving trains, it stirred my practitioners of engineering, and they're professionals who invent, design, analyze, build, and test machines and such. And so basically, as I appreciate it, engineers are those that use science to solve problems in our communities and how we live better. And so I looked into engineering, and as you can see on this slide, there are many different types of engineering professions to pursue. And as I mentioned, I identified mechanical engineering and petroleum engineering as the areas that I would pursue. I could go into more details about a part of another conversation, but if you can look at this list, there are many and varied areas where the sciences and math that you study can be used to improve the way we live and to investigate the problems and challenges that we have in the world. As far as the oil and gas industry, petroleum engineering is largely used in the oil and gas industry. And there are three areas primarily in the oil and gas industries called upstream, midstream, and downstream. I'm not going into details, just letting you know that there are many different areas in the oil and gas industries where petroleum engineering and actually all forms of engineering are used. And in the oil and gas industry, upstream, midstream, and downstream, that is exploring for oil and producing the oil and gas, then processing it and refining it and taking it to market and using it in all of the areas where petroleum is used. Just so you can appreciate, crude oil is used for so many different parts of our lives, not just for gasoline. We use crude oil to provide materials to make all of our plastics. Everything that's made of plastic is what is called a hydrocarbon. And crude oil is a hydrocarbon. And so you use that to make all of your plastics and everything. Your asphalt come from crude oil. So making roads and there are many and varied. You can as I mentioned, upstream, that's where you find the oil and gas. Exploring and producing for crude oil and gas from the ground. Downstream is where it's going into refining, processing, and into marketing. And the midstream is how you get it from the well sites. And I say well sites, that's where you drill a hole into the ground and you find the hydrocarbon deposits underground. And then you move that from the well site to the place for processing, and you use transportation pipelines and storage. For exploration and production operations, this is where petroleum engineering comes in. You use geology, that's one of the sciences, to find out where the oil and gas may be found across the world underground. And petroleum engineering is used to find out how to get that out of the ground. The reservoirs where oil and gas accumulations are found, and then you drill into the underground reservoirs and produce the oil and gas. This is a high level and very simplistic, but to give you an appreciation for what the industry is about. And I just mentioned all of these to you. The types of petroleum engineers are places where petroleum engineers will work: reservoir engineer, drilling engineer, and a production engineer. During the course of my 38 years in the industry, I've done all of these. I was a production engineer when I started out in 1970s. That was to get the oil and gas out of the ground and to get it through the process and to the marketplace. It was part of my responsibility. Drilling engineer working on rigs, platforms offshore, rigs on land to actually do the physical drilling underground to find oil and gas reserves. The reservoir engineer is the one who quantifies the oil and gas underground. Hopefully that stirs your awareness or give you a sense that there's a lot involved in getting oil and gas out of the ground. As I mentioned, reservoir engineering, these are folk that evaluate what's underground, how much is there, how profitable it is to drill for it, and to see what you can get out of the ground. A drilling engineer, as I mentioned, that's someone process of identifying how to drill by developing a well plan, design a drilling program, and do the well operations. And there are a lot of different parts, moving parts in the drilling process. A production engineer is someone who and optimizes the process of getting oil and gas out of the ground. All right. And so I can move along here. How do you become? And for those of you that are in high school, depending on where you are in your high school process, key areas of focus, just a general scientist is someone who wants to solve problems that are in our communities. Math, physics, chemistry are all crucial forms of focus. Just one of the things I like about engineering is it's not so much memorizing all of the formulas that are out there and the things that are in math. These subjects teach you how to solve problems and analyze problems and to apply these to the oil and gas industry. So algebra, calculus, and geometry, the physics, and the chemistry. As I mentioned, petroleum engineering is my primary area of profession. I was a mechanical engineering student. There's chemical engineering and electrical engineering come all under petroleum engineering. One of the things about petroleum engineering, and particularly right now, there are some pros and cons that you should be aware about the oil and gas industry. The pros, these are high-paying jobs. The salaries are very good, but they're unstable. And if you're paying attention out there, oil and gas prices fluctuate. And right now, you go by your service stations for buying your gasoline, they're the lowest prices that you've seen, even at your young age. These are low gasoline prices. That's because the crude oil prices out there are very low right now. Why is that? Because the volume of oil and gas in the marketplace is high. Pros and cons, you can travel the world. That industry is worldwide and you have opportunities worldwide. And of course, a con is traveling the world. Sometimes you have to do that in work for multinational companies. It's exciting work and it can be very risky work. And this gives you an idea of what the pay scale is for those that will pursue petroleum engineering. Even with a bachelor's degree, there's significant opportunity in the oil and gas industry. And hopefully that's piqued some interest and hopefully stirred some questions. Rob, you can give me some guidelines on that, or if did I stir any questions, or hopefully I didn't put anybody to sleep.
Not at all, Mr. Simon. I actually had a question myself, and then I'll open it up to the floor for questions. Okay. So I was wondering, what do you think would be like the most challenging engineering project that you've ever undertaken?
Wow.
Most challenging thing.
I will tell you the most I've had a few opportunities to have some very challenging projects, and you may be aware of what I'm about to say. When you're drilling an oil well, one of the things that's in order to drill a well, you're drilling down underground, and you can appreciate that the deeper you go, the higher the pressures are. And so one of the things that you have to do in order to drill miles down below the surface is to control the pressures from down below. And we use mud. That's a kind of a crude, well, that's an interesting word to use, crude, but that's the mud that we use to keep the pressures under control. And so the challenging is having tapped into a pressure that's higher than the weight of mud that you're using to control your drilling as you go down to find the place where you're looking for oil and gas. So controlling pressure underground is one of the risky things and the challenging things. And I've been on 2 wells that threatened to blow out as part of my career. Didn't have any real consequences from it, but it was challenging to be on site to try to get a well back under control when it's releasing gas and threatening to blow out. Hopefully that answers your question.
That does. Thank you so much.
There are
And we
many
have,
other things that are challenges in this industry, not the least of is having the instability in the oil prices. I've seen those over the 38 years that I've been in the industry. So there's some risk getting into it. One of the things that I would say to minimize that risk is not to pursue petroleum engineering exclusively. Get another engineering field and perhaps parlay that into the oil and gas industry, but you also have a fallback into mechanical engineering, computer engineering, electrical engineering in other industries. But if you lock yourself into petroleum engineering, you're kind of locked into the petroleum engineering field.
all right. Thank you so much. And we have some questions from our viewers. Do you get to travel to faraway locations, or do you just work in the same?
Yes, I've been to Central America. I've been to Spain offshore. I've been a part of drilling wells offshore Spain, and in Central America, and in yes, I've traveled even to the UK.
All right.
There are those that have traveled more and lived away. The longest I've lived away from home has been for a month at a time. There are stories involved, but I want to leave Serena some time.
Okay, another question. How did you get your first job? Do you remember the experience? And how big was the jump between college and an actual job?
Oh, that's a good question, because I would encourage everyone that's interested in any career, particularly as you're in college, look for internships, opportunities to at least test the water. If you're interested in going into the oil and gas industry, look for internship with those types of companies, or with the company with computers, or whatever industry you're interested in. See if you can get an internship, because it has a twofold benefit. The company is looking to see if they would be interested in you, and you can also see if you're interested in the industry or the company. And so that would be my advice, is to look for opportunities and internships so you can get exposure to various industries. Hopefully that's a beneficial response there. Look for internships or co-ops. You might want to look into co-ops or internships.
Okay. And how long do you think it would take to become a petroleum engineer?
How long? Are you meaning studying?
Study.
Okay. Well, typically it's a 4-year degree. And so that should be 4 to 5 years, depending on how you schedule your classes and such. But it's typically a 4-year degree, and if you do the internships, you generally have a job waiting on you when you graduate.
Okay. And what do you think about your work-life balance? Do you think you're satisfied with your work-life balance?
Now, I've been in the industry for 38 years. You kind of learn how to navigate that. You can appreciate when I started out, and actually technology has improved things considerably since I first started. When I first started out, I had to go to rig sites at 4 and 5 o'clock in the morning because you had to get morning reports to be able to do the business of the industry. But since there's technology, you don't have to use fax machines. You don't have to call in reports. Everything can be done online virtually now. So people can do a lot of stuff remotely. And so it makes it easier to maintain a healthy work-life balance.
Okay.
So technology has improved that.
Do you think petroleum engineering was affected much during this global pandemic?
Yes. Yes, because just many different things, like all industries where there's challenges on the workforce and the demand for the type of restrictions. There are layoffs, and I've seen a number of them take place. And quite frankly, with people staying home, not traveling as much, not flying as much, the planes use a lot of energy. Automobiles use a lot of energy. So the demand for some of the products are less than they usually are. And so the price of oil and gas, petroleum products, naturally fall. And so there are decisions that are being made in the industry that makes it very unstable right now. So hopefully
So
that
now answers the question. All right, yeah, that's perfect. And this next question actually truly impressed me. Do you think being a petroleum engineer will stay a safe job with the modern shift towards more environmentally friendly fuels?
That's a very, very good question. And my answer would be to anyone who's interested in petroleum engineering to pursue it with that in mind. And so you should have, and just so you'll know, every corporation that's in the oil and gas industry have that as part of their profit model, is how to become energy efficient and be more environmentally friendly. So you shouldn't shy away from the industry as if it is entirely working against having a greener environment. That's a challenge within the industry itself. In fact, one of the things that you can see is that natural gas is a more desired pursuit than crude oil nowadays, because natural gas is a cleaner fuel than burning crude oil, and there's less pursuit of crude oil because there's a greater benefit to pursuing natural gas.
All right, thank you so much, Mr. Simon. Do you have any other last comments to make?
Well, hopefully I haven't turned anyone off from petroleum engineering. I just want to give you, so that you can go in it with your eyes wide open. If there's an interest, my advice, not just because I've done it, I have a dual degree. But petroleum engineering is still a lucrative profession to get into, but it's highly competitive because there are a lot of folk that go into it, and the instability has returned in the industry. And so I would suggest that anyone that has a desire to go in it have a second area of focus, like mechanical engineering, chemical engineering, electrical engineering, computer engineering, that make it a composite degree. And that's not hard to do, because then you'll start interested in petroleum, do it from other than a primarily petroleum degree, if that makes sense to you. Oil companies hire mechanical engineers to do petroleum engineering work. So that would be the smart move. If you want to go into the oil industry, go as a mechanical engineer or electrical engineer to do the other work.
All right, thank you so much, Mr. Simon. It doesn't look like we have any other questions left from our viewers.
Those
Thank
were
you
good
for your
ones.
presentation. Thank you so much. And right with that, we'll go straight into Dr. Tang. Do you think you're ready to take it away?
Sure. Do I need to be the host? Oh, sorry.
Yeah, I'm going to turn it. If I've got to release it, I'll turn it back to you. And if I leave, that's because I've got another meeting in a little bit. So I'm not being.
I won't be offended.
Okay.
Thank you. I learned some things too.
Well, I'm glad to hear that. All right. How do I, let's see, somebody shared with me how to do that. Who am I to give it back to? Give it to you?
Yes,
Rob?
sir.
Yeah.
To Serena.
Dr. Tang.
Yes, you can give it straight to Serena.
There you go. Enjoy.
Okay. Looks like I'm the host now. All right. So then I'm going to pull up my screen.
Yes.
Can y'all see this? Everything looks okay?
We can't see your screen.
Oh, you can't see my PowerPoint?
Screen. No. At the bottom of the Zoom, you just click on the green share screen button, and then it will pop up.
PowerPoint. Share. All right. Can you see it now?
All right. Yes, we can see it now.
Okay. So this is a reference that y'all probably won't get. Maybe some of the organizers will get it, but it's a song from the Eurythmics, and it's called Sweet Dreams Are Made of This. And I thought it was appropriate because as anesthesiologists, part of our job is to put you at ease and help you have a nice rest and fall asleep. And I often suggest to my patients that they pick out a good dream. So I'm really excited to be here. Thank you, Jenny, for inviting me. And I can't wait to tell you about what an anesthesiologist does, because I didn't really know until I was kind of far along in my medical training, and I had already done a pediatrics residency. So most of the first physician you've ever met is your general pediatrician. And then I did a pediatric critical care fellowship. Then I decided I was going to go back and learn how to do anesthesiology on adults, and then did a subspecialty to do pediatric anesthesia as well. So I have 4 board certifications. And had I known what an anesthesiologist does, I might have been able to kind of combine some of that training. So let me move this screen so I can see what we're writing here. All right, there. So an anesthesiologist is a physician, first of all. Hold on, let me make this go away. All right, there we go. Is a physician who puts patients to sleep for surgery. The more important part is we keep them safe. We are experts in airway control, meaning the breathing tube that's put in the actual breathing. So a lot of people, when they go under anesthesia, will be on the breathing machine. And then circulation. So making sure that your heart is pumping, that your organs are getting all the blood and oxygen that it needs. We're experts in IV access. Sometimes that's just a regular IV, your standard IV. Sometimes it's a bigger IV that when we need to push blood products or blood pressure medications, or even bigger IVs that when you need dialysis or things when you have kidney failure. We watch, monitor, maintain those vital signs to keep the patient in a state of suspended animation so that the surgeons can do their job. We work closely with surgeons, and our communication is very important to understand at what part of the surgery they are, at the beginning, at the middle, at the end. Are they expecting a lot of blood loss? Are we expecting that there's a risk that they might endanger some vessels, or that may lead to bleeding or cut some nerves because the tumor is kind of engulfed around the nerve? We manage the ventilators, we give medications, fluids, and blood products. And most importantly, we'll wake up the patient. That's the most important of our job. Everybody thinks we just put them to sleep, but putting people to sleep is a little bit easier. It's making sure you get that patient awake and back to their family the way that they were before. All right, so anesthesiologists are actually everywhere in the hospital. We're in the operating rooms. We're in what we call non-operating room areas. So say if you had to have a study to get an image of a tumor in your brain, you might need a CT or you might need an MRI. And there are some people that are very claustrophobic and they can't stay in those tight spaces on their own. So they might have an anesthesiologist administer sedation or general anesthesia to go to sleep. We are in labor and delivery. So probably when you were born, your mom had an epidural to help her with the pain of delivery. And we're the ones that put those epidurals in. We are in the intensive care unit. That's part of what I do as well, is I do pediatric critical care. So we take care of the sickest children in car accidents, who have cancer, who have infections that overwhelm their body. But then there's also the adult intensive care unit. So all the patients that are super sick because of the COVID pandemic right now, those are the ones that end up in the adult intensive care unit. They're adult patients that go after surgery. They're not safe enough to go home and they still need some recovery. So they may end up in the ICU. I will talk about the COVID ICU in just a little bit. We are also in code teams. So a lot of the times when you are in a hospital setting and there are patients that are trying to die for whatever reason, we have something called the code team, or you may have heard, if you've been passing through, somebody call a code blue. And that is the overhead page or an actual pager page or a phone call that says, I have a patient on this floor in this room that is dying right now. And as the team leader, the anesthesiologist is the one that will often run the code. We need to give this drug. We need to order this test. We need to call for more help. We need to put in a breathing tube. We're the one that everybody looks to because we're the airway experts. Not everybody can put an airway in. You've probably seen on TV, on ER, some of those shows where they're putting a breathing tube in somebody's mouth. It goes through their vocal cords, and then it delivers oxygen to their lungs. And that is a very tricky thing to do. And the majority of our training is to learn how to do that safely. Because we have patients that are newborn to patients that are 400 or 500 pounds sometimes. And you still have to be able to put a breathing tube in all of those patients. And then also, this may seem a little surprising, is that we're in clinics. There is a specialty of anesthesia called chronic pain. So as you get older, if you've injured your back or were in a car accident and you have pain that just won't go away, anesthesiologists can do certain injections to help alleviate the pain. And those are often done in clinics and in outpatient setting. We kind of do everything. Any organ system that you can think of, there is probably a subspecialty associated in the anesthesia realm. So cardiothoracic anesthesiologists will study extra time to specialize in those heart surgeries and the lung surgeries. There are solid organ transplant anesthesiologists, specifically in New Orleans, liver transplant anesthesiologists. Our Ochsner, our liver transplant program, does more liver transplants than any hospital in the country for the last few years. So we have a very busy transplant program. There are neuroanesthesiologists, so anesthesiologists who specialize in surgeries that involve the brain and the spine. As I mentioned before, the obstetric anesthesiologist. I'm a pediatric anesthesiologist, so I take care of a lot of babies, even though I do some adults as well. There's something called regional anesthesiology. So if you're having shoulder surgery, we can numb up your shoulder and your arm. If you're having knee surgery, we can numb up your knee. If you're having finger surgery, we can just numb up that regional area of your body. And then, as I mentioned before, chronic pain anesthesiology. And they do long-term treatment for patients who have painful conditions that are ongoing, not just related to a surgery or an incision. So a day in my life, I will usually get up around 5 o'clock in the morning, and I have to be at work between 6:15 and 6:30 because our OR start at 7 a.m. So I'll go see the patient in the morning, make sure that they haven't been sick, they haven't been running fevers, cough, those kind of things that the anesthesia might be dangerous for them to go under, because our anesthesia gases can be pretty irritating to the lungs, or if we don't think the patient can handle the stress of surgery right now, and there are things that can be done to optimize them. So once we're in the OR, we put on all our monitors. So first off, we'll watch your heart rate, we watch your blood pressure, your oxygen saturation. Sometimes we do more invasive monitors, but we start off to get a baseline idea of where the patient is, because not everybody that comes in for surgery starts off healthy. There are patients that are already admitted in the hospital that might need a surgery as a complication of their hospital course. So they may come to us with a heart rate that's higher or lower than normal, or a blood pressure that's higher or lower than normal. So it's important to have that baseline to know where you're starting off, and that's kind of your goal for the case. We will give oxygen, then give some IV medications to kind of deepen the anesthesia and get them to sleep. A lot of times I'll give some relaxing medicine, and I kind of joke with patients, and I was like, all you have to do is think about what deep, dark secrets you'd like to share with me, and we'll keep them all safe. But if you can build a rapport with the patient and kind of relax them and take away some of that anxiety, let them know that you're there for them and you're going to take good care of them, then it can actually go a long way in smoothing out the process and making it a much more pleasant experience for them. So after I give the medications to make them go under anesthesia a little bit deeper, we do place the breathing tube, and that's called intubation, or intubating a patient. And then we set the numbers on the ventilator, which we may end up adjusting during the case depending on how the surgery interacts with their normal body physiology. We may give some IV fluids, titrate pain medications, titrate the anesthesia gas. And when I say titrate, I mean I'm looking at their heart rate and blood pressure to give them a little bit more, or give them a little bit less, or give a different medication, kind of given the situation. But at the same time, not burn any bridges, because at the end of the case, I might want to get them breathing. And if I give them too many narcotics or pain medications, sometimes that can make you stop breathing. So then they would have to be on that breathing machine and that breathing tube for a much longer period. So we have to really balance what we give to them and anticipate where if they're going to go back up to the ICU with a breathing tube, or if they're going to go to the recovery room breathing on their own. So at the end of the surgery, as I was saying, we'll let the anesthesia gas wear off. And then when we remove that breathing tube, we call it extubation. And so we do this multiple times a day, each anesthesiologist. And we have about 55 or 60 anesthesiologists at Ochsner. And so multiple ORs are going at the same time. We're all kind of going through a very similar process to get patients off to sleep safely and maintain that anesthesia, that pain control, the forgetting what's going on so they're not waking up during anesthesia. And then at the end of the case, waking them up and getting them safely back to their families. So in the spring of this year, our world's all changed. And it really, somebody had asked a question about whether the pandemic had affected our industry, and it absolutely did. But in the opposite way than it affected almost every other industry. We were hit hard in New Orleans, as y'all all well know. You may have been relatively insulated from it because walking into the hospital in March, it was a ghost town. It was empty until you got up to the ICU, and then it was chaos. The emergency rooms and the ICUs were overwhelmed with 6 patients. They all needed airways because they were having trouble breathing. They couldn't breathe on their own, even with supplemental oxygen. They needed breathing machines. They had low blood pressure. Their kidneys were failing. They needed the small IVs. They needed the large IVs. We just had so many patients hit us all at the same time, we think, because Mardi Gras was a few weeks before, and everybody was having fun, sharing drinks, sharing food, like sharing all kinds of beads and throws. So if you were sick and you were on a float and you were asymptomatic or you didn't know you were sick, that bead that you threw off the float was going to spread the virus to somebody else. So we were so busy that we actually canceled all elective surgeries. So meaning the surgery isn't an emergency. Say you had a bump on your finger that you want to remove, that's not a life-threatening thing. They were going to put it off till later. So all the elective surgeries got canceled so that we could help decrease spread and then also have ORs and ICUs available for the people that really need it, because some of our patients that needed surgeries were going to have to go to the ICU to help to recover for a few days, and we just needed all the ICU beds that we could get. And then the COVID pandemic really changed the face of what it meant to be an anesthesiologist. We were redeployed to work in areas of the hospital that we normally don't go. We may go up to the ICU to help out and put a breathing tube, but we don't stay there the whole day or the whole week. Or this actually went on until May, from March till May, where our anesthesiologists were asked to go help in the COVID ICU, whether we were actually rounding on the patients or just doing procedures. That's me in my full face N95 mask that I got during the peak of the pandemic. So once they got up to the ICU, some patients have, even though they had a breathing tube and even though they were on the ventilator, which is the breathing machine, they still couldn't breathe. Their oxygen levels would dip really low, and you're maximizing the treatments and the interventions that you could do for somebody in that situation. So we resorted to turning some of these patients to lay on their stomachs, which is called proning the patient, because you have more lung available on your back. And so if they weren't laying on that bigger segment of lung, it would be able to participate in oxygenating their blood a little bit better. And as we know, the COVID virus was really affecting the people that had lots of comorbidities, which means they had other problems: asthma, diabetes, high blood pressure, and obesity. And we were seeing patients who were literally 300, 400 pounds that we would have to flip onto their stomachs with a breathing tube in, and then 8 hours later, flip onto their backs again to give them a break. And then 8 hours later, we would come and flip them back on their stomachs. And these people were staying in the hospital for weeks at a time. And every 8 to 12 hours, we would have to flip them. So the anesthesiologist created this prone team. That's me and some of my coworkers as we were going from bed to bed to try to help turn these patients over, because it wasn't just so much that they needed the manpower to turn the patients over. They had a breathing tube, and that tube easily gets dislodged. It's only stuck to their face by tape. And so we needed airway experts to go in and make sure that those tubes stayed in the right place. And then on top of that, all of the patients' pressure points were protected, so that we would actually tape their eyes closed so that they wouldn't, as they're being sedated, their eyes wouldn't get scratched by the pillows or anything like that. We'd make sure their arms are in good position, that they had the correct pillows to cradle their face without causing extra pressure. All those things are things that we do in the OR, because we end up positioning patients in different positions for surgical access as well. So we're kind of known as the jack of all trades. Those ICUs weren't used to having to turn those patients on their stomach and on their back all the time for weeks on end. And we talked about dislodging the breathing tube, and that, so they called the anesthesiologist up there, and we were, in addition to putting the breathing tubes in, a lot of these patients end up needing dialysis because their kidneys weren't functioning. So we would put in these very, very large IVs in the veins in their neck or in the veins in their groin, so that they could take the blood out of the body and filter it and put the blood back in. And we did this from March until May. So what does it take to be able to do this? You have to be able to work under stress, under pressure, in a very dire situation, and still you can be stressed out, but you still have to function. You have to have strong communication skills to be able to talk to the surgeon or talk to the ICU doctors or find the nurses and be able to communicate with them, because seconds count. And if you cannot clearly communicate with confidence what you need or what you think needs to be done, then it could waste time. Like I said, we are the team leaders in code situations, so you need to have good leadership skills. A lot of the things that we do, because our patients, when they're in their OR, are under sterile drapes, and you're just using their vital signs and your ventilator and those kind of things to figure out if there's a problem, what it is. You have to be able to kind of methodically think through solutions for things and have good problem solving skills, in addition to time management skills, because so many things in the OR are happening at the same time. You don't have time to say, I'm going to do this first, then this next, then this next. Sometimes it all happens at the same time. Because we do a lot of procedures that are not necessarily surgery, but kind of in that surgical realm, like putting in those large IVs and those dialysis catheters, you have to have some manual dexterity, the stamina to work long hours, and the also emotional stamina, because we were seeing patients die left and right. We would come, put a breathing tube, put in the large IVs, and then next door somebody would be passing away, and they would take that body to the morgue and then turn around and fill it with another sick patient who needed our help. And because of all this, being compassionate and having a lot of empathy for people who are at their most vulnerable is really important as well. But in addition to all the scary, like crazy stuff that goes on in the hospital, there are other reasons to do this. It really opens the doors where you could actually work part-time anywhere around the world and around the country. And then also, one of the things that I love about anesthesiology is it gives me the opportunity to do mission trips. And so I travel around the world, or have traveled around the world, to do anesthesia for babies who are having cleft lip and palate surgeries. Most recently, the last couple of years, I've done this in Ecuador. So the skills that I learned in my schooling and in my training, in my day-to-day job, I can use to go help people in less fortunate countries as well. For example, this is called a unilateral cleft lip and palate. So when the babies are developing in their mom's stomachs, they're the face doesn't fuse together like it's supposed to. So you can imagine that this baby that says 2019, he has difficulty eating and growing, although he looks kind of chubby there. But it's also going to affect his speech, how he sounds, how he articulates. And then there's a big social stigma if he grows up without that being repaired. And then you can see like what a wonderful job he had done for fixing that one-sided or unilateral cleft lip and palate. And then here's a picture of a baby who had a bilateral cleft lip and palate. So both sides didn't fuse the way they should. And then to look at him after his surgery, that's life-changing for him for so many reasons. So this is one of the things that I love doing, is going out into the world and helping other people who don't have the resources that we do in the United States to have these type of surgeries. So with all that said, how long does it take to be an anesthesiologist? Well, you're dealing with life and death situations, so it takes a long time. You have to be good at what you do, and you have to be able to think on your feet and do it quickly. So after college, it takes about 8 years. Most people, if they're going to go into medicine, will have to do medical school. And when you get out of medical school, you have the MD degree, but you're not really a doctor. The only thing you can do on your own is maybe do some research. So everybody who graduates from medical school still has to do what's called a residency, where you're in training and you're learning to perform the tasks that you have chosen to do. So a residency could be, if you just want to take care of kids, you would go into pediatrics. If you just want to do adults, you might go into internal medicine or family medicine. If you want to do surgery, you would do a surgery residency. If you wanted to take care of pregnant women, you might do an obstetric residency. So those are the types of general training programs that most people do. In the first year, because you don't really know anything yet, is called your intern year. So to do anesthesiology, after your intern year, you have 3 years of clinical anesthesia practice. And those are our anesthesia residents for all 4 years, but they really are not in the OR until their second year of the 4. And then some people, after they just do regular anesthesiology, might decide to specialize like I did. And I learned how to do anesthesia specifically for children. And again, in this realm, you can learn how to do anesthesia specifically for liver transplant patients, specifically for pregnant women, specifically for heart surgeries. That's optional. Not everybody does that. And you could be a general anesthesiologist and take care of a little bit of everything, maybe in private practice or in a small rural area. But if you want to be in an academic center where we are teaching other residents on a continual basis, like new residents come, the old ones graduate, and you're a part of that education process in an academic center, then most people are going to want you to subspecialize and do a fellowship. So then I did 4 years of college, 4 years of medical school, 3 years of pediatric residency in Portland, Oregon. then 3 years of pediatric critical care fellowship in Denver, Colorado, 3 years of anesthesiology residency, and then another year of pediatric anesthesiology fellowship, also in Denver, Colorado. So this is not the typical path that most people will take, but I just loved what I was doing so much, and it made me such a better physician to be able to have that solid pediatric background and then the critical care background as well, because critical care and anesthesia go hand in hand, which is why as an anesthesiologist, we are all able to go into the ICU, the critical care unit, and function over there and be helpful. Would I do it again? Absolutely. I love my job. I love taking care of kids. I love taking care of adults. I've actually taken care of newborn babies and 100-year-old adults in the same day. So if y'all have any questions, I'm happy to answer them. Or if we don't get to them today, then you can talk to Jenny and she can reach out to me through email.
All right, thank you so much, Dr. Tang. We actually have several questions for you. They've just been coming in.
Okay,
and so,
let me see how I can get out of this.
All right, yeah. At the top, you can see view options. And then from there, you can stop screen share.
I have this little thumbnail is the only thing that I have. Oh, wait. Nope. I mean, I can see y'all, so I think that that's fine.
Okay. All right. So we will go ahead with our questions. So one viewer asked, he wants to be a physician. However, he sometimes gets grossed out with the insides of a body. Do you have any tips on overcoming this fear, or would it just require more practice in general?
I think it's a few things. Everybody that is seeing blood and guts for their first time, they're going to get grossed out because that's not a normal thing. I think you have to think past it and think about how you would feel if you were the person who was the one on the table with their guts hanging out and somebody looked at you and they were like, ew. And knowing that you can help them helps you move past it. And the more you see it, the more used to it you get. Like still right now, eyeball surgeries kind of gross me out. Broken bones kind of gross me out, but give me blood and guts and I can take that all day. That doesn't bother me at all. So it's just really being exposed to it more.
All right, thank you. And can you be part of different fields when you first study anesthesiology, or do you have to stick to one specific type?
So actually the purpose of the anesthesiology residency, in addition to teaching you how to do airway, breathing and circulation and IV access, is to give you exposure to all the different subspecialties. So the residents are required to do rotations in pediatrics, liver transplant, cardiac, regional, all those, an OB, all those things, everybody will do at least 1, if not 2 to 3 months of training in. So because you may not know what it means to be an OB anesthesiologist until you're the one putting in the epidural and you're taking the pain away from a pregnant woman and she decides to name her baby after you because she's so happy.
Okay, next question. Is overtime common for you? What do you think about the work-life balance in general?
So of all the medical specialties, there are several specialties that are much more difficult to get into because the compensation is good and the lifestyle is good. And so I think with anesthesiology, when you're there, you're working hard and it is very stressful, but you also have that work-life balance because you're well compensated and you have time away. Nothing comes for free, right? You're not going to get a high-paying job with no stress, really, or work long hours and not get paid as much. So there's a reason, like our malpractice is high, the risk is high, the stress is there, the burnout is there. But this is one of the few specialties that you actually do get pretty good work-life balance.
Okay. And how would you describe your college experience, especially with all of the workload and prepping for exams like the MCAT? How did you feel about it when you were doing it?
So it's never fun, right? And the work-life balance that comes when you're done. It's not going to be while you're training. So you definitely have to be strong in your math and sciences. But coming into med school now, people are actually looking for mature mature candidates who maybe have had a different career before, because you bring that level of maturity and experience to the table. They're looking for people who are not so naive, thinking that if they only study science and only study chemistry and math, then they're going to be a great doctor. Because to be a physician, you have to be all those things. You have to be well-rounded. You have to do service to show that you're going to do something for nothing, right? That you're not in it for the money, because you can get paid a lot more, a lot quicker doing some other field than spending years and years and years doing the training like that I did. You will make enough to eventually pay off your student loans, which I'm not quite there yet. So studying for the MCAT, taking the courses that you need to do, but also showing that you have a little versatility. Maybe you major in English or minor in music or something like that, to show that you are a well-rounded individual, that you're not going to spend every single moment of your day studying, because then you're going to burn yourself out and you're going to be stressed out. And then those are the people that are going to crack under the pressure. So they're actually really looking for people who come from diverse backgrounds, diverse experiences, life situations, show that you have some empathy for what somebody else's suffering is, those kind of things.
Do you have to take any extra COVID precautions when going home, visiting others?
Oh, absolutely. So I had a young teenager yesterday that showed up for surgery, and we were testing everybody for COVID when they come in. They check their temperature. Everybody wears a mask in the hospital, and masks do a wonderful job of helping to prevent it. But when you have a patient, so he showed up positive. He was asymptomatic. His mom got tested 3 days ago because she had surgery 3 days ago. He shows up for surgery the day of, and then is COVID positive. So I actually wore what's called a PAPR. It's a purified air, like positive pressure respirator. So it has a battery pack on the back, and it blows positive pressure so that you're not breathing in any COVID particles that are around. It actually blows air through your mask to give you fresh air the whole time that's filtered. I wore what we call a bunny suit, which is like a disposable jumpsuit that you can pull up and zip up so that you're not exposed. I double gloved. And then as soon as that's called donning your PPE to put it on. And there's a specific process in doffing so that when you're taking it off, you're not contaminating everything. But we take extra special precautions. We have a separate OR that is the OR that's used just for COVID patients. There's a separate elevator that's just used for COVID patients. And everybody has at minimum the N95 mask on and eye protection.
All right, this next question particularly intrigued me. So how does hormonal imbalance impact the amount of anesthesia a person's body can handle?
So that's interesting, because I think there's so many things that may go into play in hormonal imbalance, and you have to think of like the underlying reason. Is it that this patient has a tumor that secretes hormones or certain types of chemicals that is what we need to take out? And there are lots of situations that if you poke that tumor or if you take it out the wrong way, you can send somebody off into like a crazy, what we would call storm, where their body just goes out of whack, out of everything that you are thinking of doing. One of those in particular that we all learn about in medical school is called a pheochromocytoma, and it's a tumor that's on your adrenal glands. And there's a certain way that you have to treat their high blood pressure that's as a result of that hormone secreting tumor. You have to treat it with this particular drug first, then treat it with this particular drug first. Otherwise, you may kill that patient. So there's a lot of things that that hormonal imbalances can affect your anesthesia, and that particular division of medicine would be called endocrinology. So those physicians deal specifically with the hormones, which are very complicated. If I ever have a patient like that, I'm always looking through the notes to see if the endocrinologist has left a note, or I'll call them. That's part of that communication thing. The nice thing about being in New Orleans is it's like such a small town. I'm like one of my neighbors is an endocrinologist. So if I really had a question, I would just text her and be like, hey, can you help me out here? We call it a curbside, where it's not officially asking them a question, but I'm just picking your brain to learn a little bit more.
All right, and this next one, how would you say priority is chosen between patients who need help at the same time?
That's such a broad question, but when we talk about anesthesia for emergent cases, we will class them. So a class A is a surgery that needs to go within the hour. Somebody is bleeding out, something is about to rupture, somebody is like dying and will die without the surgery. So we call that a class A. A class B is a surgery that would have to be done within 4 hours. So it's something urgent, but not emergent. So you can wait a little while you're getting everything together, optimizing things, setting up your room, but it really shouldn't wait because you might risk life or limb. And then a class C has to be done within 8 hours. So it's not a real emergency, but it's probably maybe you're taking out a tumor that, like a breast cancer or something, that doesn't have to be done within the hour or within 4 hours, but it probably shouldn't be done 3 weeks or 6 months from now. So we kind of stratify our cases based on that type of classification. And we always have an OR that is available and ready and staffed in case there's a trauma that comes in, like the emergency you weren't expecting.
Okay, so you say that you were redeployed earlier this year. How would you say the transition was when you had to work in other parts of the hospital? Was there anything new that you had to learn, or was it an easy switch?
So I think in those types of situations, the system is often what sabotages you. So it's not the medicine or the skill set that you have. It's like knowing who's whom, knowing who's the charge nurse to let them know you're there to help, knowing where the equipment is, because you're really only as good as what you have. If I have to put a breathing tube in, but I can't find the breathing tubes, that patient's not going to do too well. So knowing who your resources are up there, familiarizing yourself with the layout, because it's kind of a labyrinth sometimes. So those are like the systems issues. Like, how do I get my medications quickly when I'm used to just drawing it out of the drawer and checking it out myself? When you're up in the ICU, usually the doctor has to put in the order, it has to go to pharmacy and get filled, then it has to go to the nurse who's then going to administer it. So that all adds minutes, time that you can't be wasted. When we are in the OR, our medication is right there. We are the respiratory therapist, the pharmacist, the doctor, and the nurse all at the same time in the OR, because there's no system of checks and balances where you have a nurse checking your order or a pharmacy checking your order. You have to know these things, and they have to be second nature. So I think that those are the issues when you go to an unfamiliar area like the ER or the ICU. It's nice because they're always excited to see you because you bring a service that they aren't able to do for themselves, but you're kind of floundering because you don't know where everything is.
Okay, so you said a 1 to 2 year fellowship is optional, but do you think it could help more with getting hired? What advantages do you think would come with a fellowship?
100%. I think the return on your investment on a fellowship is very, very high, because when you're right now, medicine is one of the safest areas to go look for a job, because we're in the middle of a pandemic. It's probably not going to go away very quickly. We had job security. We were one of the only fields where people were still going to work and not, staying at home or sheltering in place or being able. That's why I don't know how to use Zoom, because I don't really use it because I can't work from home. So I think if you find something that really speaks to you and really interests you, and you think that you could do it for a long time, absolutely worth considering a fellowship. You give 1 or 2 years of your life up for that fellowship, but you may get paid more because you're subspecialized and there are very few people that could do what you want to do. Or the benefit may just be that you're more marketable because you have a skill. And in addition to being a general anesthesiologist, you are very comfortable with children, or you're very comfortable with laboring women. And so if I were going to hire you and one person had a subspecialty and one person didn't, who am I going to pick? Because the person with the subspecialty can do both jobs. The person who did general anesthesia can probably just do one. And that's what Mr. Simon was talking about kind of diversifying. He has 2 degrees also, so that he had a backup plan, a fallback if he didn't like something or couldn't get a job in that area. So I think that's always good advice.
Have there ever been a few times when you've had to do your job incredibly quickly because your patient didn't have enough time? And when you first started out, how did you cope with that kind of stress?
So that happens every other day. Kids in general are not just little adults. They have different set of disease processes, and they have so much less reserve. So if you think about the size of your lungs versus the size of the lungs of a neonate or a newborn baby, they are so much smaller, and their other organs are immature. So they just cannot tolerate anesthesia as well as adults can from maybe a respiratory perspective in general. So they will drop their oxygen very quickly. So whenever I'm teaching the residents, I tell them to listen for that oxygen monitor. And if it drops by 1 point from 100% to 99%, I want to see you looking to see what's going on. Whereas an adult, they might be 99, 92, 94. And like, it's not that big of a deal because you have time. They have much more reserve. So it actually happens not infrequently. And again, just like the being squeamish around blood and guts thing, the more you see it, the more you expose yourself to it, the less stressful it is because you've seen it before and you saw what we did. And then you see it a second time, you remember half of what we did. And you see it a third time and you're like, oh wait, I remember a lot of what we did last time to treat this and get myself out of the situation. So by the fourth time, you're like, okay, I know how to handle this. I've been in this situation. And then the fifth time, you're actually doing it with confidence. And that's what we're looking for when we're working with residents, trainees in the OR, is for me to kind of transfer those skills where they feel confident doing it on their own. And the next time, I might just stand outside the door and watch from the window, not let them know that I'm there, and see how they try to get themselves out of that situation. So we're constantly watching them very closely to try to help them deal with those situations. But for everybody, it's scary. The first time you think that a patient is going to die on you is very scary, because if you're a resident, you feel like you've got a safety net because you're attending. I would be calling attending right now is there. But when you're the attending and like the buck stops here and you think that patient's going to die on you, that's a very, very scary moment. But we're never alone. I have 7 other pediatric anesthesiologists who work with me, and they're always just a phone call away.
All right, thank you. And our last question of the day, especially when interacting with patients under anesthesia, what would you say was the most interesting experience you've had at work?
Interacting with patients under anesthesia?
I think what they mean by the question is, all those videos that we've seen where people say a lot of different things when they're on anesthesia. What would you say was your most interesting experience with that?
Oh, but I told you, whatever happens in the OR stays in the OR, and they tell me their secrets, and I promise not to share them. A lot of what we do, again, is to make the patient feel at ease. So when I go into them in the morning and I do my preoperative evaluation, I try to make it more like a conversation rather than an interview. Do you have allergies? Have you ever had seizures? Do you have asthma? Those kind of things. But I try to make it a little lighthearted, but you also have to kind of read the patient and make sure that they're not so anxious that they don't want to hear your jokes. They just want to sign that consent, and then you leave them alone. So that's why I always kind of prep them for just think about which deep, dark secrets you want to share with me, or those kind of things. Because then they think that they're going to give away all their secrets. So they're trying to think of which ones they don't want to talk about. But then it's at the forefront of their mind. So then you start to push the medications, and then they were feel like it's confessional. So I've had several people tell me stories. And one guy said he was literally going off to sleep, and he said that my old girlfriend from high school messaged me on Facebook and said, I think my oldest son is yours. And then he fell asleep, and I was like, well, I'm not telling his wife. So I feel like in anesthesia, you can be super awkward around people and not want to deal with them. They're asleep. You don't have to interact with patients or those kind of things. But if you have a personality and you can build that rapport and take some of that anxiety away from the patient, then you can be super effective at your job in just the 5 or 10 minutes that you have with them while they're awake.
All right, thank you so much. And with that, that is the end of our first night of our shouting program. Thank you, Dr. Tang, for taking part in our program. Thank you, Mr. Paul and Mr. Adam, for putting this together. Dr. Tang, do you have any last comments for our viewers?
No, I love my job. I would do it again in a heartbeat. And I think if anybody's interested in medicine, try it. This is the time to be out there, to be taking care of people at their sickest. I heard an article or a podcast on NPR saying that medical student applications are up 27% since the pandemic hit, because people really want to go out there and be a part of something great and take care of others. And I think if that's where your heart is, you'll do well. If you're doing this for the money, there's so many other things you could do to make more money in a shorter amount of time. So.
All right. Thank you so much, Mr. Paul, Mr. Adam. Thank you as well. And for everyone,
Welcome.
Mr. Paul, Mr. Adam, do you have any last words to say?
No, we had a great time. It was very informative.
Thank you. I had a great time too.
All right. Thank you, everyone, so much. Thank you to all of our viewers for showing up. I hope you all learned something and will use this to your benefit. And if you're interested in a career in law, then tune in tomorrow night at the very same time to hear from a couple lawyers who will be our guest speakers tomorrow. Once again, thank you guys so much. Good luck, stay safe, and happy holidays.